Well, my task is to now talk of a situation which again doesn't have a lot of evidence, just as Professor Prasad mentioned. There are areas where we do not have a lot of understanding, and like was mentioned, that some things which the cardiologists do, we sometimes contest it, sometimes we follow it, and in general what the cardiologists do claim that we as neurologists do the same thing what they did 20 years back, for example the interventions. So my topic today is going to be dealing with how do I thrombolize within when you suffer an MI. Let's see if we can reach a consensus what the cardiologists deal and how we deal with certain situations. So thrombolysis in acute MI is always been a bit of a problem, and even not only is a problem of the treatment, there has been a conflict even with the guidelines. So the guidelines which have been evolving, and the previous guidelines kind of prevented us from treating at a certain time limit, which probably didn't have a basis. So if I just look at acute MI versus stroke, the reperfusion in MI was tried many years back in '76 and came in clinical practice much earlier and much faster than what happened for stroke. Whereas acute stroke was first tried in '76. And you know about the NINDS trial, but even after the NINDS trial, the recommendation and the guideline came officially in 2003. Now we do have, of course, reperfusion, which is coming up. So just to exemplify, we have this case, one of our patients. So I will compare a case how we managed back in 2013 and with the current era. A 58-year-old diabetic hypertensive coronary artery disease patient had a STEMI on 19th of October and not thrombolized. Patient was presented to PGI with unstable angina 2 days later, 3 days later. PCI was done by the cardiologist on 22nd of the same day, and 2 days later, noticed to have a right-sided hemiparesis with aphasia. So patient had a normal CT, a CT angio showed a major LVO. Now this is 2013 when mechanical thrombectomy was not approved, and all of us were trying our hands at a lot of other interventional means like intra-arterial thrombolysis, etc., etc. So before I go on to what we did, let's look at the incidence of MI following the stroke following MI. It's believed, we don't have exact figures, but around 23.9 per 1,000 persons is the approximate incidence which for stroke after an MI. And simultaneously it may happen in up to 5% of patients. The biggest complication what we fear when the patient has MI is a hemopericardium, and that's why the biggest fear of treating the patient with TPA is the patient may have a cardiac rupture. Usually this may occur within the 48 hours. Usually it occurs with anterior wall and extensive STEMI. That's what has been previously described. In non-thrombolized MI is 1 to 5%, whereas in STEMI after thrombolysis is considered to be high. The only risk factors known are older age and an extensive STEMI, which has been previously elaborated. Non-STEMI we don't know, and it's considered that non-STEMI patients may have a low risk of all these complications of non-STEMI and cardiac rupture. And primarily of all the data, if we look, 5 patients till now have been documented from the time that the licensing of the TPA was done. And these 5 patients happened in usually they happened in the high-risk STEMI patients. So theoretically the risk stays maximal in 4 to 5 days in the first few days of the stroke. And by the 6th or 7th week, usually the scar organizes. So theoretically, if you treat a previous patient who's had an MI with thrombolysis, after 7th week, theoretically, the risk is almost negligible. But you know about the guidelines, which still wait till a long time said 3 months and still says 3 months. So what were the guidelines? Now, these are the old guidelines or the license. I'm talking of the license. The alteplase insert says recent MI is a contraindication. Is not a contraindication, whereas guidelines, American Heart Association considers it as a contraindication. The European guidelines had rejected it quite a few years back, and so had the other studies. How about the 3 months, the 3-month contraindication that does not actually have any hardcore evidence? Like I did mention, that most of the risk is there in the first few days and is almost mitigated by 6th to 7th week. So what can be considered is it's reasonable if you have a patient beyond the 2nd month, and if you have a simultaneous MI and stroke. In case of both have events, the stroke window, we can undergo a you can go ahead with a thrombolysis because that is known to even be beneficial for the heart. Sorry. So an older guideline, if we look at the previous guidelines before 2016 and 18, 3 months of MI has been a contraindication. If the MI happened 3 months back, you're not supposed to. So what we did for our patient was, we took the patient at that time in 2013 for an interventional procedure, since the patient was with the cardiologist. So the patient was taken to the cath lab, and I remember talking to the cardiologist at that time. The catheter was taken with a stroke to groin puncture of 60 minutes at that time. And at that point of time, patient was given intra-arterial TPA. And cardioembolic strokes, as we all know, are fibrin-rich, so they respond very well. So patient did have recanalization, a small hemorrhage, and had a recovery. So let's fast forward to 2019. How would we be treating a patient who's got a similar kind of a picture? So interestingly, I just noticed that patient also came on 19th of October. This happened 2 weeks back. And the date's it's kind of a chilling recurrence. The same situation happened in 2 months back, a month back, on 19th of October 2019. Well, I didn't change the dates, though. That was an old slide. I just happened to notice. Exactly. So this patient gets MI, or not an MI, gets a chest pain, goes to a district hospital close to PGI. Now we are now currently in a program where we are linking our district hospitals to PGI to assist them in thrombolizing and dealing with acute strokes. So this patient gets a treatment which we believe was just a sorbitrate or oral nitrate and is sent back. 2 days later, on 21st, the patient comes back with right-sided weakness, dysarthria, and goes again to the district hospital. Now this time, as we call it, the Stroke Net Chandigarh, it's put on our discussion group, and the ECG is, the CT is done, onset to door time is 60 minutes, the patient reached within 60 minutes of the stroke. The BP was a bit high, NHS was 9, so moderate to severe stroke, aspect 9, TROP-T was positive, so the resident who was dealing was he was quite shaky, he didn't really want to risk using thrombolysis. He sent me the ECG, which looked like this. This was the ECG on 19th when he had the chest pain. So first this ECG was sent, which kind of gave this acute ischemic picture with ST depression and tall T waves. On the day when he arrived, this has switched on to this kind of a picture with inverted T waves, and a TROP-T was positive at that time. So considering at that point of time, patient having a very good CT scan, I suggested to the resident, go ahead, please thrombolyze, but he was not willing to take the risk, and so the patient gets referred to our institute. And when the patient reaches to us, the CT angio was done because CT angio is not there with the district hospital, and we find no LVO, and we immediately put the patient on IV TPA. So with a door to CD5 needle time of 30 minutes. Now this door to needle is for PGI, and the total onset to needle was around 180 minutes, 3 hours, so well within the window period. Repeat TROP-T was done, which was negative, and CKMB was done. This was done within the next 24 hours. We treated the patient. This was the EKG, which happened immediately post thrombolysis, and we did notice that the T wave inversions were a bit less than what they were there. I won't comment on these. I'm not a cardiologist, so I won't analyze the ECGs in serial wise. The patient went on to improve the NHSS. 24 hours 6, day 9th he became 1 and MRS 1. When I just saw him this week in the OPD on Wednesday, he was almost close to recovery. And this was the post-stroke day 2 EKG. Again, we are seeing that the changes are receding. The cardiac changes were progressively receding. Of course, the cardiologist did an echo which didn't show major significant findings like a clot or systolic dysfunction. The EF was good. The scan, the MR, which was done again 2 days after the stroke, showed a small hemorrhage and basically, it's a ACA infarction, which is a small ACA infarction. A small hemorrhagic conversion can be seen on the left image. So what are the recommendations? Like I said, the previous recommendations clearly did mention do not thrombolize if you've had an MI within the last 3 months or ischemia. They didn't specify acute coronary event or MI, but MI, yes, definitely. So, but this patient, if I were to take a corollary with this patient, the patient did have a TROP-T positive at that time, and as the resident feared, we would have not been sure of, treating this patient had we gone with the previous guidelines. So, if MI and stroke happen together, the recommendation is to treat with TPA followed by PTCA. This is a class 2A recommendation by the American Heart Association, which came in 2016 for the first time. At least clearing certain situations which we do encounter, having MI and stroke together. Patients come within few hours of both the events. It does happen rarely. What happened significantly in 2018 was the time period for, although MI remained the same, but the recommendation for treatment for non-STEMI became clear. That to thrombolize a patient with non-STEMI, it is reasonable. For STEMI, if you have a right and inferior wall, right inferior MI and left anterior MI, you can treat the patient with a class 2A recommendation. And jumping to 2018, we've had almost a similar thing, which is now recommended for patients presenting with stroke and a history of recent MI in the past 3 months. Treat the ischemic stroke with IV alteplase is reasonable if there's a STEMI involving right and inferior. If you have non-STEMI, you're safe, but if you have a recent MI involving the left anterior, it still may be reasonable. So there's a difference of is and maybe. And again, this completely depends upon the clinician who's looking at the patient, and a decision rests upon the physician. Now, importantly, if we go back to the studies which were previously described, the basic pathology which we deal with in the myocardium, by 6 to 7 weeks, if you had complete resolution of the scar, the 3-month window period is kind of not very scientific. So although the recommendations do retain the 3-month window period, it's practical enough if the patient has had it over 6 weeks in time in the past. So beyond that, the recommendations remain the same. Now, only in the case you would do a PCI, for example, a coronary stenting, the antiplatelets may have to be started earlier. So there have been studies which have reported it as safe, but we don't have any current guidelines for that. And post-stroke MI, just to make a note, this usually is uncommon thing, usually are painless, and they have a high mortality and associated with hospital stay. The usual reasons being that the clot in the heart, which gets disrupted and goes into the coronary, that may be the main reason. So if just to conclude, the heart and the brain, as we considered, has a conflict. Over the time, we have learned how to take care of both the things. We've evolved, and guidelines are also gradually changing for us to understand how safely we can treat a stroke following an MI. Thanks.